Excellent. So while we start, I just want to share with you some disclosure regarding my relationship with Johnson and Johnson for sutures and also for polyethylene design. So in the using traditional technique for knee replacement, do we fulfill patients' expectation? If you look at the literature and in your clinical practice, you see many patients who feel that they cannot perform some daily activity, like being able to kneel, being able to squat, and it's about 30% of our patients who have these limitations. 50% of them have residual symptoms after knee replacement. 75% of them do not experience a natural joint, a forgotten joint. And 100%, if you test them in a gait lab, they will show abnormality in their gait. So there is a large room for improvement in our knee replacement. Lowering patient expectation, is it a solution? There are papers saying that if you tell the patient that they will not be able to do this and that, maybe they will be happier after surgery. Is it an option today in 2026? I believe it is not. Our goal should be the same as the patient, to improve their quality of life to a level where they will forget about their joint that has been replaced. With 50 years of total knee arthroplasty with mechanical alignment, we need to understand what was the downside of this technique. If we look at patient anatomy, we reviewed 4,800 lower limb CT scan, and you see the graph here. Anatomy of human being is follow a bell curve. The widespread distribution of anatomy is quite, as you see on the graph, is quite large. And if you apply mechanical alignment principle to the anatomy of patients, of human being, you find that only 4% of the people have a neutral femur, 5% have a neutral tibia, and only 0.1% have both at 0 degree. So with mechanical alignment, we reproduce only 0.1% of patient anatomy. This is only for coronal alignment. There's something here. I cannot move anymore. Next slide. No. Oh yes, that's okay. So keep in mind that every joint you replace is unique. You have millions of different variation of human anatomy, and all parameter will be combined together, creates a unique joint. So this variability in human anatomy, if you modify patient anatomy, what will be the result? You will create soft tissue imbalances. There will be kinematic axis modification, and also it will lead to functional impairments. With systematic technique, when you modify anatomy, we worked very hard to try to describe some solution. The work from Leo Whiteside on ligament balancing. So you try to catch your tail because you create the problem, and then you try to solve the problem by making some other modification. Knee replacement, I will try to show it is not a soft tissue operation. It's a bone operation. And we published a paper in Journal of Arthroplasty a few years ago. I tried to bring up all the flaws of mechanical alignment. I would suggest, if you want to know a bit more, to read that paper, because if you're convinced that mechanical alignment is not the ideal solution, you may be open to jump on something new. In 2019, we declared, Charles Rivière and I, my past fellow, that it was the end of mechanical alignment era. And I thought it would go very fast and the change will happen in the year later, but still today it is taking time. And at the same time, there was Larry Dorr, who passed away recently, who declared that the death of the Lewinick safe zone. So both group believe that the systematic technique for hip replacement and knee replacement is not the solution in the long term. So we decided to create the Personalized Arthroplasty Society at that time to speed up adoption on these new concepts. and create some discussion. Because the traditional society were still low on discussing these new principles. And this is the goal of personalized arthroplasty. And we wrote a book that is free online. If you want to access that book, I think it's a good option to start learning about these techniques. And then I propose that it's time to redefine knee replacement. And why personalized arthroplasty is the future of knee surgery? Because it involves three pillars. Three pillars. The first one is a patient-specific perioperative care that we'll discuss a bit later this morning. Second is joint anatomy and function restoration, the forgotten joint. And last is the lifetime implant survivorship. If we can provide these three pillars, then we succeed at a personalized surgery. Today, this morning, I'll speak more about the joint anatomy and function restoration and a little bit about lifetime implant survivorship. There is this nice pictogram done by Takafumi from Japan, showing what are the three key elements to restore kinematic of the knee. First, morphology of the joint, implant design. Second, alignment, orientation of the implants that you can control with your surgical technique. And the soft tissue balance, tensions, that also is in your hands and your control during the surgery. A pioneer in the field of personalized surgery is Stephen Howell. I think he will change forever the face of knee arthroplasty. Since 2009, he proposed to resurface the knee joint. He called it kinematic alignment. And if you understand the technique, it is if you remove 10 millimeter of bone, you replace by 10 millimeter of implant. So this is a true restoration of the pre-arthritic joint surface. You don't want to restore the disease surface. You want to restore the pre-arthritic. This is very important. So in 2011, I listened to Stephen in a conference. And I thought, oh, this might be the solution for my patient, and it changed my life from that time. I started to do kinematic alignment technique, but in that period of transition for me, I had these two questions. Before reproducing all anatomies, like it was proposed by Stephen, I thought, what is the normal anatomy of the lower limb? Does pathoanatomy exist? First question. Second one, what anatomical parameters are compatible with implant material available today and the method of fixation? So how to define normal and pathology? This is a very old question. You see here this article in Lancet in 1947. At that time, the question, what is the normal hemoglobin level? What is the normal glucose level? And they had to define what was the normal value. To define normal value, they use the link between the value out of the mean of the bell curve leading to a disease. So if you have a very high blood pressure, you may have a stroke, heart disease, kidney disease when you're above 160 of systolic pressure. So then they created that normality and abnormality comprehension. In hip surgery, you will all agree that a dysplastic acetabulum is something probably pathologic, and you will never put your acetabular cup in anatomical position in a dysplastic hip. Why? Because you know that this is incompatible with polyethylene wear, maybe instability, so you will try to modify this pathoanatomy to have a successful hip replacement. In knee replacement, I believe this is the same story. There are some very severe disease, hemophilia, Charcot joint, spondyloepiphyseal dysplasia. You've got this blunt disease creating abnormality of one joint out of the two. And when you have unilaterality, for me, it's a sign of pathology. It's totally abnormal to have one knee with such a varus deformity and the other side more normal. You have soft tissue pathology that happen over time in these very severe valgus knee, as you can see here. And again, it's unilateral disease. So in this paradigm change from systematic to personalized surgery, we should not adopt another dogma with unrestricted kinematic alignment and treat all patients the same way without discrimination. So avoiding the recognition of pathoanatomy, I think it's not looking at the human being as it is with some pathology. So the question is not, should there be some limit? The real question is, what should be the limit of a kinematic alignment protocol? So in the early ages of my practice with personalized knee arthroplasty, I created the restricted kinematic alignment technique, and I published the fundamentals of that technique. It involves 5 fundamentals principle. And you can see here, I will not go in detail with these principles. You can read my paper. I think it's well described. And this is for the people who are interested to go more in detail in their surgical technique. But you can see that I put some limits on the hip, knee, ankle angle and on the joint obliquity level. To follow these 5 principles, I created a very simple algorithm that you can follow easily. And this algorithm will favor the restoration of femoral anatomy because this is the leader of the joint. So I'll try to perform most modification if it's needed, only in about 50% on the tibial side. This is a case I want to show an example of a patient with a severe varus. I perform a restricted K surgery, bilateral surgery, 1 stage, and the patient is walking with a cane the morning after the operation. This is part of the success of my ERAS protocol and also from kinematic alignment principle, not doing any medial release and performing very minimally invasive surgery on the soft tissue. Now, as I mentioned, these boundaries will evolve over time because I strongly believe that the extreme deformity will not be compatible with current implants. But then there is a room where we don't know. Let's say the patient with a 4-5 degree HK, we might expand the boundaries that I use in the restricted kinematic alignment protocol. The limits of K I want to share with you because now we see some publication on LinkedIn, the new science, and in some papers. This is a case that was presented on a post, 7 degree varus tibia. Everybody would say, oh, this is a perfect unrestricted K, but 5 years post-op, you see loosening of the tibial implant. So then this patient required early revision after 5 years. So this might be an example of the limits of unrestricted K. Another paper recently published after 13 years with a HK of 5.5 degree varus, this patient developed polyethylene wear. This paper is coming from, I think, Croatia, and I told the author, it's great that you publish this case report because we need to know that what are the limits. If we don't publish failures, we will never know. So this is an example where maybe a HK of 5.5 is maybe outside of the normal, the tolerance of a normal total knee. So another example here I want to share with you. You see these cases. I see them very frequently on LinkedIn. This is a pre-op film and then the post-op film. Is this K? I don't believe it is K. If you just look at the plain X-ray, you draw the joint surface that you would like to reproduce, and then you translate this on the post-op film. For me, this is not K. It's a surgical error. So then with mechanical alignment, it was very easy to assess success. You want everything at 0. So everybody knows that you did a good job or a bad job. When you do K, you need to look at pre-op and then compare to post-op and see if you replicate patient anatomy. And it's not because the tibia is in varus that you did K. It's you need to restore patient pre-arthritic joint surface. So we need some precision tool. We need accuracy because we're talking about millimeter and degrees. If you're aiming at 3 degrees, 4 degrees, you need to be able to achieve that precision. And there are multiple methods. We'll discuss that a bit later. But I know Mike Dunbar, I value a lot of his thinking, and you had him as a speaker, I think, last year. He published that paper that we need to evolve beyond craft surgery. I mean, you will never go on a jet if they're relying on simple tools. You want them to use computers, some navigation tools that are sophisticated. So in surgery, probably we should have the same. Now let's talk about the valgus knee. Valgus knee has always been more difficult, reported as a complex surgery, difficult to balance with mechanical alignment. And now there are people who continue in this thinking process saying, oh, K is probably not suitable for valgus knee. For me, this is completely wrong. In my practice, valgus knee become much easier than before. I think that the value for valgus knee is even better than for varus knee. So looking at papers like this and the comments of some surgeon, I published last year a paper saying that valgus knee deserve a personalized total knee arthroplasty. And please take some time to read that paper because I explain why valgus knee anatomy is really affected by mechanical alignment. And if you respect these patient anatomy, you'll make your life much easier and patient success higher. This is an example of an 86-year-old patient with a valgus knee. MCL was not stretched, so a stable valgus knee. There was a femur valgus, distal femur at 8 degrees, so we reduced it to 5 according to the restricted K principle. And the varus with tibia was varus 2, so 5 plus 2 create a valgus HK of 3 degrees. And you see the post-op film. We have an oblique joint line, but the patient was very stable with a cruciate retaining polyethylene without any releases. This is the patient who 4 weeks after surgery, very happy with the result, a good range of motion. And he's got now a HK of 3 degrees, which is much better than his disease state. And he feels that his knee is back to the alignment he had when he was maybe 20 years old. Patella is tracking well. Most of these valgus knee have dysplastic trochlea, so I do not worry about downsizing my femur. And you see here a small notch of 1 millimeter, 2 millimeter. And for me, this is the way to go for valgus knee. Downsize your femur, translate laterally as much as possible, because these implants have not been designed to be put in kinematic alignment. They have been designed to put mechanically aligned. So each degree of valgus that you put in your femur, you're changing the trochlea angle of the implant. So we need some specific implants available for these patients. So RK for valgus knee in your surgical approach, please take care to the medial collateral ligament. Do not detach the deep MCL at all because you will destabilize the valgus knee. The MCL, in your experience in valgus knee, is very thin. It's not, and it's very easy to stretch. And this is your key of stability in this patient. This is another case, a bit more severe. You can see pre-op evaluation. There was no real firm endpoint to the MCL. So I could tell from physical exam that I would probably need a semi-constrained insert. So in this patient, I cut the femur at 5 degree valgus, tibia at 3 degree varus, and I had to use a semi-constrained polyethylene to compensate for the MCL that has been stretched by the disease. So personalized TK is a game changer for the valgus knee, as I just mentioned. I think it solves many of the mechanical alignment challenge, and but also consider the associate factor. All these patients with valgus knee has hip problems, soft tissue laxity, they have patellofemoral pathology, they have foot problems. So it's not only a knee disease; the whole lower limb is problematic. You should also take in account the patient preference. If you ask patient, interestingly, this is the first paper I read about, who asked the patient, what would be your preference after surgery? Do you want a straight lower limb, or you prefer to keep your limb a bit bow or a bit knocking knee? And they found a difference. People with up to 5-degree varus would believe that their lower limb is straight. But valgus knee, more than 2 degrees, they believe that their lower limb are not straight. So then you see a difference in patient preference. And that's why, I felt that my boundaries with the 3-degree valgus maximum would match patient expectation and preference. So this is something that we need to consider in our decision, not only bone anatomy. This is the clinical result of this patient preference. This is a paper published by a Slovenian group. Patient had a mechanically aligned right total knee that was not perfect because it was left with 2-degree valgus HK, but patient was very happy. Then they tried to do a kinematically aligned left total knee, which restore a 7-degree valgus HK. And patient was unhappy about the left total knee. She said, you should have done like my right total knee, which was perfect. And then she had to undergo a revision of the left side because of unsatisfaction. So this is just a message about taking in consideration all the aspects of the care you're providing to your patient. For me, this is personalized care, not only looking at anatomy, not looking only at the implants. It's taking patient in the equation. And then if you have specific cases, complex cases, we tried with Charles to publish a classification with 7 categories, trying to help people to know what would be the compromise to do if you cannot restore patient anatomy because they have a severe problem, maltracking patella, insufficient ligaments, severe contracture. What would be the option to make a compromise between kinematic alignment and mechanical alignment, something in between? So this is something that might interest you. Performing restricted kinematic alignment since 2011, I had good success. I did mainly cemented implant in the first years, and then I switched to a mix of uncemented and cemented. Since now, zero revision for loosening, zero patellofemoral complication, and in the last 10 years, I stopped resurfacing all my patella unless they have a severe wear and patellofemoral problem. I published the results of my first 100 patient at a bit more than 10 years with 99% survivorship and 95% satisfaction of the patient. So this is different than the traditional 20% dissatisfied patient published in the early years by the London group. And also I published a paper with a bit more 5 years of follow-up with uncemented implant, showing uncompromised osteointegration of the implants with kinematic alignment. If we look at the literature comparing RK to unrestricted K, using the same implant, which was interesting, the three, let's say, long-term publication, Owl, Dossett, and my cohort. You see the success after 10 years, 98.5% for Owl, 84% for Dossett. and 99% for my patients. But the main difference is on the patellofemoral complications. Quite high with Dorset. He was using PSI instruments, so he could not make much adjustment during surgery, and ours got 1.8%. And most of these patellofemoral complications are linked to extreme femoral orientation, and it comes back to the point where the implants are probably not designed to be put at 6, 7, 8 degree of valgus. What are the limits of unrestricted KA literature? When we discuss about should we restore all anatomy, Stephen say all the time, oh, I never had a problem with extreme patients. But in his long-term cohort, if you look at these extreme cases, there are only 3% of his patients with HKA above 6 and only 4% with the tibial component above 6 degree. So then we cannot make science of these small number. If we want to make a real study, we would need to make it a multi-center study using RSA, for example, and then collect 50, 60 outlier case, and then follow these patients with RSA for a few years and know if these extreme anatomy will perform well. So in a single cohort of a surgeon, it's very hard to have enough outliers to make a conclusion. The answer might come from the East. You know, the people in Japan and India have a lot of extreme anatomy. In this paper recently published of 427 patients, there was 40% of patients with the HK above 3 degree and about 16% of their patient with tibia above 6 degree of varus. So then if we follow these cohort for a long term, we might see if we can go to these level of extreme value. To make up your mind about going unrestricted or restricted, you can read these two editorials. I replied to Alexander Nedopil and Howell in one editorial about unrestriction, and I believe this it would make sense at the moment to be a bit more conservative unless we have strong data in the future. Keep in mind that knee anatomy is much more complex than only lower limb alignment and coronal alignment. There are multiple other factors like the tibial slope, trochlear alignment that you may consider, and we need to put all these parameter into AI, into a software to help us make better decision because it's too complex for us to manage on its own. We discussed about the surgical technique, alignment, soft tissue. Now, if we look at morphology of the joint, implant design, this is another part that will come in the future. As I mentioned, there's so much variation in joint anatomy. We talked a bit yesterday with the resident about the polyethylene design between PS, mobile bearing, CR. Now we have the medially constrained or medial pivot design, which is much nearer than the normal kinematic. And also, as I mentioned, the orientation of the femur may require a reorientation of the trochlea. So we may go to more on a custom implant design in the next future. It's already there with Conformis in US, with Symbios in Europe, but it's still in the early ages. If you ask the engineer at these two companies, it's not clear the customization exactly where it goes. But I think this is the next step, the next part that should be incorporated into personalization. We should abandon the mean value thinking. I think adopting a more human and precise approach is very important in medicine because having a one-size-fits-all solution, we know in multiple aspects of medicine, it doesn't work. It's a period of transition and confusion for people who teach how to do simple surgery. Mechanical alignment was simple. Everybody was doing the same. But now it's become very confusing because we have now new names: kinematic alignment, functional alignment, restricted K, inverse K. And then what is the truth? What is the proper solution? And you need to read and discuss with expert to understand what is the goal. And you can perform these technique multiple way: caliper technique, computer navigation, robotic assistance, PSI. So I think it's you need to read a lot, go to meeting, and then to make your own perspective. There is a lot of science to be done because all the science we know have been performed with the systematic technique. Paper, for example, that compare the cruciate retaining versus posterior stabilized forgotten joint score were all done with mechanical alignment. So does these comparison will stay the same if we do a personalized approach? It might be different. So same for patellar resurfacing, and think about all the ideas that we need to do again with a different approach. And I visited the McKeag Center yesterday. I was so impressed by what you have available in Calgary, that you have everything to do all this science here. If you're motivated, you can do fantastic randomized study with the gait analysis and the investigation tool that you have. Above science, patient experience is something that I value a lot. This is part of personalization. One of my good friends, Jean-Paul Brutus, he wrote a fantastic book, Elevating Your Patient Experience. I would suggest you read that book. It's available on not eBay, but Amazon. And I published a paper this year on the way we could improve patient experience. And this is not medicine. This is the way we care about the environment, the way the presence we have with the patient. And I understood that this, I'd call it perioperative intervention, is as important for the patient as your surgical technique, or even more. Personalized care is focusing on the individual need, but I totally understand that it's very challenging to perform such personalization in a constrained environment. We lack time, manpower, we need teamwork. Sometimes it's not available. And also the finance needs to be there. Administrators should be on board with you if you want to do these things. So I would suggest first to do better and then faster. Today we're pushed and we see people who do 12, 14, 15 cases in a day. How can you be personalized and provide good care as a doctor if you cannot talk to the patient after surgery? This is impossible. So moving forward, restricted K for me is the best compromise at the moment. Pathological anatomy, I'm sure, exists. There are bony anatomy that are problematic, and ligament laxity, pathology, contracture, I'm sure you have seen. Implant material and fixation method currently are limited, where still occur. It may change over time. So boundary will evolve along with science and knowledge, but I'm sure that restriction will persist. Thank you.